Ah, Thank you, Abhishek, and thank you, Pranab, and your entire team of Abbott for hosting this evening's webinar and requesting me to speak on a very important and very common uh, clinical condition with which we come across daily in our clinical practice, which is related to the gastrointestinal motility. That is gastroesophageal reflux diseases and functional dyspepsia. So we shall be recapitulating our knowledge of this very common condition with which we come across in our day-to-day practice, and we shall try to focus our attention on the role of prokinetic and how the introduction of prokinetics helps the symptomatology and the etiological treatment in the management of functional dyspepsia and GERD. We shall also be devoting some time on the issue of diabetic gastroparesis, a very common accompaniment of long-standing diabetes, which poses a problem in treating the patients. And we shall also see how this prokinetic molecule etopride brings about a change in the symptomatology of diabetic gastroparesis patients. So in next 30 or 40 minutes or so, we shall be dealing with these different aspects of this functional dyspepsia and gastrointestinal reflux diseases. We all know GERD is a condition that develops when reflux of a stomach content causes troublesome symptoms with or without complications, and the typical symptoms of GERD is regurgitation, heartburn, chest pain, and dysphagia. Other symptoms like dyspepsia, nausea, bloating, sore throat, globus sensation, and epigastric pain are also sometimes there. And we all know this is due to the defect in the lower esophageal sphincter. And this sphincter opens, allowing the reflux of the acidic gastric content in the lower part of the esophagus and giving rise to this symptomatology of heartburn, chest pain, and dysphagia. And this is quite a common condition, accounting for more than 5.6 billion visits to the physician each year, and 10 to 20% of adults in Western countries and nearly 5% of those in Asia experience GERD symptoms at least weekly. Prevalence of GERD symptoms is increasing by about 4% per year, and in 2015 the total direct economic impact of GERD and its complications was estimated to be over $18 billion. So you can see how in the terms of economy this affects this common condition affects the economy. And we all are quite conversant with the factors contributing to the GERD. As I alluded to earlier also, transient lower esophageal sphincter relaxation is the main cause, and sometimes sliding hiatal hernia. Then change in dietary patterns also gives rise to some symptoms of GERD. Obesity is quite a predisposing factor, and delayed gastric emptying due to any cause may lead to these symptoms of GERD. Then increased esophageal junction distensibility, then acid pocket development, and lower esophageal sphincter pressure. These all are factors contributing to the development of GERD. And we all know that gastric disaccommodation increases the number of transient lower esophageal relaxations. So gastric disaccommodation is the important component in the causation of GERD. And as a subset with functional dyspepsia, that is up to 40%, also has a failure of gastric accommodation, accounting for the overlap of functional dyspepsia and GERD. And symptoms of these two overlapping conditions could be either upper gastrointestinal symptoms like abdominal pain and postprandial distress, and it could be lower gastrointestinal symptoms in the form of diarrhea and constipation. And we know that the higher prevalence of dyspeptic symptoms has been noted in patients with GERD, suggesting that the degree of overlap is greater than could be predicted through chance alone. So GERD and dyspepsia shares common pathophysiological mechanisms, and the two most important pathophysiological mechanisms are visceral hypersensitivity and altered gastrointestinal motility. And GERD and functional dyspepsia overlap exist, and this is highest. And we can see in the different studies, a nationwide study of 1 lakh individuals within the Danish population implemented a web-based questionnaire survey, and it found that GERD and functional dyspepsia was associated 1.9%, GERD with irritable bowel syndrome in 1.7%, and GERD with functional dyspepsia and irritable bowel syndrome in 1.6%. So these are the common gastrointestinal and functional dyspepsia symptoms associated conditions. And in another study carried out in France, this functional gastrointestinal diseases overlap to be was found to be as high as 72% in all 3,318 GERD patients using the Rome 2 diagnostic criteria. And GERD symptoms found to be associated with an increased prevalence of functional gastrointestinal disease. In another Swedish study with a sample size of 1001, that is Alexander study, found functional dyspepsia in 16% patients when applying the Rome 3 criteria. And the overlap of GERD and functional dyspepsia was found to be about 3.9%. In another study from Denmark, with a sample size of 49,706 individuals who underwent a web-based questionnaire survey, this shows the prevalence of GERD in about 11.2%, functional dyspepsia in 7.7%, and irritable bowel syndrome in 10.5%. Overlap between GERD, functional dyspepsia, and irritable bowel syndrome was seen in 6.5%. And in another study from Korea, this prevalence of GERD was seen in 7.1%, and overlap between GERD and uninvestigated dyspepsia was found in 3.6% of the respondents. And a total of 50% of GERD patients also complained of dyspepsia, and 46.4% of patients with uninvestigated dyspepsia also had GERD symptoms. So you can see all these studies from this table summarizes the salient points of these different studies. I am not going into the details. And we know that the risk factors for GERD and functional dyspepsia overlap may be more GERD symptoms and insomnia, anger rage, abdominal pain, female gender, anxiety, cigarette smoking, and somatization. These may be risk factors. And greater mean somatization symptom checklist score and increased use of proton pump inhibitors escalates the odds of developing an overlap. So these conditions may escalate the development of functional dyspepsia and GERD. This table gives you a rather pathophysiological link between functional dyspepsia and GERD. Genetics is also involved, and esophageal acid exposure, motility, then visceral hypersensitivity, inflammation, and roles of mast cells and lymphocytic infiltration have been involved in the functional dyspepsia and for lymphocytosis in the GERD. Then inflammation, comorbidity with a variety of psychological factors such as somatization, anxiety, and depression is noted in both functional dyspepsia and GERD. So there is these provide a link between these two conditions. Criteria for diagnosis GERD. This must include at least one of the two criteria: mild symptoms occurring more than one day per week of or moderate to severe symptoms at least once a week, impaired sleep at least to some extent, or impaired daily activity at least to a lesser extent, and mild symptoms occurring at least once a week or moderate to severe symptoms at least 2 to 3 times a month. So far as functional dyspepsia is concerned, criteria for diagnosis must include at least one of the following, that is uncomfortably full after a regular sized meal more than one day per week in the last 3 months, and onset should be at least more than 6 months ago, and unable to finish a regular sized meal more than one day per week in the last 3 months. Pain or burning in the middle of the abdomen at least one day per week in the last 3 months, and onset should be more than 6 months ago. So these are the criteria for the diagnosis of functional dyspepsia and GERD. And this table gives you an algorithm for GERD diagnosis and the typical symptoms of GERD and eight atypical symptoms of GERD. Proton pump inhibitor trial for 8 weeks are given. If the response is there, then adjust for the lowest possible dose and continue. And if there is no response, then upper digestive endoscopy is done. If it is abnormal, treatment according to the endoscopic finding. If upper digestive endoscopy is normal, then pH monitoring should be done. And if pH monitoring is abnormal, optimize medical treatment, consider endoscopic or surgical anti-reflux therapies. And if pH monitoring is normal, then esophageal function testing like high resolution impedance manometry and impedance or pH monitoring, these specialized investigations must be undertaken. So, cardinal symptoms of this functional dyspepsia and GERD are heartburn and regurgitation, and the cardinal symptoms of functional dyspepsia are epigastric pain or discomfort. And a questionnaire seems to be the perfect instrument to diagnose GERD, and no questionnaire has become the gold standard owing to the complexity in symptom description, symptom breadth, and cross-cultural differences. Questionnaires to diagnose functional dyspepsia are not useful. And endoscopy, so far as endoscopic findings are concerned, endoscopic findings in patients with GERD includes esophagitis, erosions and ulcers, strictures and Barrett's esophagus, and role of gastric emptying scans. Routinely measuring gastric emptying in patients with functional dyspepsia is unlikely to distinguish between these two populations and is hence not recommended. And these are the recent advances in the diagnosis of GERD. We have already alluded to these conventional pH metry, pH monitoring tests, then multi-channel impedance pH metry. These are the recent advances in the diagnosis of GERD symptoms. And this impact of overlap on symptom burden and what are the clinical evidence. So these some studies have shown the evidence of overlap and their burden in different subsets of population. To investigate the impact of symptoms overlap on GERD symptoms burden, in 2,752 patients with GERD alone or overlap of 2 or 3 diseases, clinical and psychological factors were compared using various questionnaires, and patients with overlapping diseases had more GERD symptoms as compared subjects with GERD alone. And disease overlap in GERD population is associated with greater symptoms burden, higher depression and poor sleep motility. And low quality scores of functional dyspepsia and GERD patients overlapping these two conditions had a more significant impact on quality of life than GERD did alone. So, combined these two had a greater impact on the quality of life. So far as treatment of these two conditions are concerned, the guidelines recommended treatment, this API and ISG consensus guidelines for management of gastroesophageal reflux diseases, and we shall see this class of drugs that is employed for the treatment of these two conditions are histamine type 2 receptor antagonist, proton pump inhibitors, sucralfate, tricyclic antidepressants, and prokinetics. And these drugs are utilized for the treatment of these two conditions, GERD and dyspepsia, and they have different aspects of relieving the symptoms of these two conditions. And prokinetics, with which we are mainly concerned, is a major player in the treatment of functional dyspepsia. Especially functional dyspepsia, we must employ H. pylori test and eradication. If not done before, then dietary modification. And if the predominant symptoms is epigastric pain or burning, then proton pump inhibitor with or without prokinetic agent should be started. And response should be watched within a period of 4 to 8 weeks. If there is response, then try to continue or on-demand treatment. And if there is no response, then try antidepressant or anxiolytic agent, and try herbal medication sometimes, and or these cases can be referred to a specialist. If the predominant symptoms is like fullness, early satiation, upper abdominal bloating, nausea, vomiting, and belching, then prokinetic agent with or without proton pump inhibitor should be started, and response should be watched within 4 to 8 weeks. If there is response, then try to discontinue and start the on-demand treatment. Prokinetics with proton pump inhibitors are a potential treatment, and amongst the prokinetics, etopride is especially suitable, and because this is a good efficacy in terms of global patient assessment, postprandial fullness, and early satiety, shows a low rate of adverse reactions, greatly improves functional dyspepsia syndrome scores. And so far as proton pump inhibitor pantoprazole is considered, this significantly lowers reflux symptoms with functional dyspepsia in patients suffering from an overlap with erosive GERD. Etopride improves the cardinal symptoms, and you can see this study versus placebo. You can see etopride response in functional dyspepsia and GERD overlap. Etopride has shown to improve the cardinal symptoms, that is heartburn, of the overlapping GERD and functional dyspepsia syndrome. Etopride inhibits transient lower esophageal sphincter relaxations, and this transient lower esophageal sphincter relaxation are considered to be one of the major cause of gastroesophageal reflux. Patients with GERD have significantly more this transient lower esophageal sphincter relaxation than healthy individuals, and etopride inhibits this sphincter relaxation without significantly affecting esophageal peristaltic function on lower esophageal sphincters. You can see. And this etopride also decreases pathological reflux in GERD, and this significantly decreases the total symptom score after treatment, and it also decreases the total percent time with pH less than 4, total time with pH less than 4, and D-Mister score. And effects of etopride on esophageal acid reflux variable for 24 hours was studied in 26 patients with GERD symptoms. And etopride accelerates gastric emptying, improves gastric tension and sensitivity, and has an anti-emetic action. Etopride effectively decreases the pathologic reflux in patients with GERD, and these are complementary and alternative medicines also tried in cases of GERD and functional dyspepsia, and we are not going into that details. Alginate, I must describe this alginate for the treatment of GERD functional dyspepsia overlap. Alginates are neutral polysaccharides, polymers isolated from brown seaweed Phacophyceae, and are classified as dietary fibers. And this has a unique mechanism in the presence of gastric acid. Alginates precipitate and forms a gel, and this is able to reduce the number of acid refluxes and esophageal exposure time below pH 4, and it decreases significantly in both the right lateral and supine decubitus position the number of acid reflux events and their proximal migration. And use of alginate is associated with lower number of symptoms after treatment, including both heartburn and regurgitation. So an alginate-based antacid preparation has shown to control both acid and non-acid reflux. This has also shown a significant benefit not only in typical reflux but also in dyspeptic symptoms. So etopride offers therapeutic benefit in functional dyspepsia, and this is from literature review of the clinical efficacy and safety profile of etopride in functional dyspepsia. It improves postprandial fullness, it improves bloating and global patient assessment scores, it showed significantly better symptomatic relief and improvement as compared to placebo, and it provides complete relief of epigastric pain, nausea, heartburn and anorexia. Positive effect on gastric emptying and gastroduodenal motility was seen, and no serious adverse effect like extrapyramidal symptoms or prolongation of QT interval was seen with the use of etopride. This table summarizes the effects from the network meta-analysis for failure to achieve an improvement in functional dyspepsia syndrome. And in terms of improvement in symptoms of functional dyspepsia, etopride ranked second after tricyclic antidepressants. Etopride in functional dyspepsia, this is a placebo-controlled trial, and uh, the result showed that etopride was significantly superior to placebo in terms of the greatest symptom score improvement in the 100 and 200 milligram groups. So, to conclude, etopride significantly improves symptoms in patients with functional dyspepsia. And another meta-analysis report shows that etopride showed good efficacy in terms of global patient assessment, postprandial fullness, and early satiety in the treatment of functional dyspepsia, and showed a low rate of adverse reactions. Etopride can prominently improve functional dyspepsia syndrome scores. And there is significant reduction in the severity of functional dyspepsia symptoms seen with the use of etopride. As you can see, all these parameters like epigastric pain, bloating, belching, heartburn, nausea, vomiting, and anorexia, they were rather ameliorated with the use of etopride. So, regarding safety profile, unlike other prokinetic agents, etopride doesn't cross the blood-brain barrier owing to its high polarity. And as per a meta-analysis, as compared with other dopamine receptor antagonists, etopride causes a much lower incidence of CNS-related adverse drug reactions. Uh, if we compare etopride and prolactin levels, domperidone can elevate serum prolactin levels. Etopride barely elevates prolactin levels. Etopride doesn't cause hyperprolactinemia. Levosulfide may elevate prolactin levels more than 200 mg per ml in patients. So, this rather amply says regarding safety profiles of etopride. So far as cardiovascular safety is concerned with the use of etopride, preclinical and clinical studies till date show that etopride doesn't have the potential to cause prolongation of QT interval, unlike cisapride and mosapride. And etopride comparison with domperidone, none of the patients showed any QT prolongation in the post-treatment ECG from either group. Domperidone is not currently a legally marketed human drug, and it is not approved for sale in the United States. On June 7, 2004, FDA issued a public warning that distributing any domperidone containing product is illegal. And comparing etopride with levosulfide, neither QT prolongation nor serious cardiac toxicity was observed with etopride hydrochloride therapy. Only QT prolongation changes were found in 2 patients, but no serious cardiac toxicity was observed with the patient receiving levosulfide. Etopride, regarding the safety profile, key takeaways points are: etopride is well tolerated and has minor adverse effects like abdominal pain, diarrhea, and headache. It doesn't cross the blood-brain barrier, so doesn't have central nervous system effects like extrapyramidal symptoms of or hyperprolactinemia. It doesn't affect 5-hydroxytryptamine 4 receptors on the heart. Hence, no cardiac side effects of the prolonged QT interval is seen. And thus, etopride is a novel prokinetic agent, different from the available prokinetics due to its dual mode of action and lack of significant drug interaction potentials. So, this is a summary of the use of different prokinetics, and the CNS side effects of levosulfide is tabulated here, and with the use of other pantoprazole, PPI like rabeprazole, pantoprazole, esomeprazole, and comorbidities like hypertension, Parkinson's disease, hypertension, diabetes. These all are shown here. That these levosulfide doesn't go favorably with these conditions, the other comorbidities. And now we shall be see how this prokinetic etopride helps the patients of diabetic gastroparesis, and this is also quite a very common condition amongst the diabetic population, especially the long-standing diabetics, in which diabetic gastroparesis sometimes poses a problem. And this study shows the role of etopride, and etopride provided holistic approach for the management of these condition. It facilitated food delivery to the intestine, increased incretin secretions, facilitates gastric emptying, restores altered kinetics of food and drug administration, and improves HbA1c, improves fasting and postprandial blood sugar. Then there is rapid symptom relief with the use of etopride, and significant improvement in the clinical symptomatology in 8 weeks periods. These we have seen all the different mode of action, and how this etopride helps the cases in cases of functional dyspepsia, GERD, and even in diabetic mm, gastroparesis cases. These are some illustrative case presentations, and I'm not going into that detail. And all those individuals suffering from this functional dyspepsia and GERD overlap, they were benefited with the use of this prokinetic etopride. And so the key message is that GERD and functional dyspepsia, they commonly overlap. They commonly are seen in the same subsets of our population, and their prevalence and coexistence in the same individual is markedly greater than would be expected by chance. Putative role of several pathophysiological mechanisms that could contribute to this overlap include esophageal acid exposure, gastric dysmotility, and visceral hypersensitivity. Then lifestyle interventions such as exercise, diet, education, and reassurance are best for treating mild overlapping symptoms of GERD and functional dyspepsia. And guidelines recommend addition of prokinetics in patients with GERD, functional dyspepsia overlap, volume reflux, and evidence of delayed gastric emptying. So we see that this introduction of prokinetic etopride brings about a revolution in the management of functional dyspepsia, GERD overlap syndrome, and even in the management of the diabetic gastroparesis patients. Thank you very much for giving me a patient hearing.